We'll go to next talk, diabetes and food care, Dr. V.S. Rama Rao garu. Dr. Rama Rao has 16 years experience in the general laparoscopic and diabetic food surgery. He was trained at Nizam's Institute of Medical Sciences and he was trained in various hospitals in UK. He was worked in surgical oncology and other specialties.
Please.
And his areas of interest are mainly laparoscopic surgery, complex hernia repairs, general surgery, non-healing ulcers, and diabetic foot ulcers. And I would like to go ahead with your talk, sir. Thank you.
Thanks, Dr. Ramakrishna. Thanks, ma'am, for kind introduction. So, the diabetes is now a global problem with world statistics increasing day by day. That is the global diabetic map. The bluest stone shows the highest incidence. India is almost at the second level. We're going to achieve a 10% incidence of diabetes soon. So with that, all the complications like cardiac complications, foot complications, kidney complications, wherever there's an end organ injury, the complications are proportionately going to increase, and the foot complications being one among them. We have approximately 20 million diabetic patients in India, that is 2 crores. Diabetes is one of the largest, one of the single most cause for the neuropathy. And foot ulcerations is most common cause of hospital admissions in diabetes. We see people getting admitted for diabetic ketoacidosis and related complications, but not for other reasons other than the diabetic. We rarely admit any patients for diabetic control. And the diabetic foot ulcers or complications are very expensive to treat. They need hospitalization and huge costs involved in treatment care. If one of the limbs at some level is amputated, the risk for the other limb for amputation is approximately 30% in 3 years. And more than 75% of these patients will die in the next 5 years because if there is a progressive disease in the foot, that means there is a progressive disease in the heart, kidneys, and other organs as well. They die with end organ complications. So this is an indication for future complications to come. And the incidence of development of diabetic foot-related complications is around 10 to 15%. So unfortunately, when we speak about diabetic foot, we almost mean like diabetic ulcer. We never speak about a non-ulcerative, uncomplicated diabetic foot. So diabetic foot is something what we mean is the development of muscle damage, nerve and vessel damage. Nothing could be obviously seen outside, but once this pathology is there, it is a diabetic foot. So what we can do for a diabetic foot with bad ulceration or vascular complications is very little compared to what we can do to prevent those complications. So what happens, diabetes has a very long natural history, slow progressive disease. For example, if you take a diabetic and go back 20 years and see, probably during the last 20 years, either undiagnosed or undertreated condition. So there is a progressive rise in blood sugars, glycosylation and tissue damage. Probably you see nothing for the next 10 years. And then there is involvement of peripheral nerves and peripheral neuropathy. And once there is a involvement of nerves and loss of sensations in the foot, then they cause trophic ulcers, trophic changes and neuropathic ulcers. And the last 5 years, probably they develop complications related to the blood vessels. Initially, there will be some amount of microangiopathy, and then medium size and large vessel involvement, and frank vascular complications like pre-gangrene and gangrene and other things. So whatever we can do, we should be aiming at a normal foot, rather than food which presents with an ulcer or arterial compromise. So, so the taking care of the normal food is much more important. And we at IDEA have a home care package. I think these people are one of the first people to do something sort of screening for the food. So in that diabetic package, they do the screening of the food, basic physical examination and sensations and all that. And we have a graphic representation of all that in a form. So what we can do? First is the caring for the blood vessels. So, in other words, we want to prevent atherosclerosis from going on. So, we have to control blood sugar and all other atherosclerotic factors like dyslipidemia, smoking, alcohol, blood pressure, and other things. When it comes to preventing neuropathy, peripheral neuropathy, there is very little we can do other than controlling blood vessels and correcting any vitamin deficiencies. So, the last one is a physical examination, and you do whatever to identify risk factors like abnormal bony outgrowths, bony deformities, and all that, and then give protective footwear, bigger shoes with wide toe box, deep shoes, insoles, and soft cushioning soles and all that. So we should be spending more time saving a foot from developing complications rather than dealing with it. So a typical 5-minute examination of the foot should involve examining in rapid sequence, inspection, and in reverse order palpation. So we have to pick up structural abnormalities. See, skin may be involved. In case of ischemia, you see a shiny skin with hair loss. Evidence of infection, any cellulitic patches or any ulcers or any collections. And you feel the sole for any excess weight bearing areas for callus formation. And range of motion should be tested. Charcot foot is a grossly deformed foot with osteopathy and neuropathy. So then we have to do a basic peripheral arterial examination. If you feel the dorsalis pedis and the posterior tibial normally, that means it is a well perfused foot which barely requires any more investigation. And then obviously a skin temperature which is colder means there is a badly involved circulatory system. Ankle brachial index is more of an academic tool rather than what we do in clinic. What we do is take a normal BP and put a cuff on the just above the ankle, and then inflate the pressure above the normal systolic pressure, and put a Doppler on the dorsalis pedis and see and drop the pressure. So when the pressure you divide by the normal systolic pressure. So that's one of the very sensitive indicators for showing critical ischemia. Neuropathy assessment is a very simple tool, is a monofilament test. Monofilament is something like one of your toothpaste bristles like thing. It's a strong wire. So you ask you put the patient to close his eyes and touch with it, and ask whether he can feel it or not. Loss of sensation is a very sensitive indicator for peripheral neuropathy. So end of 5 minutes examination, you should be able to conclude whether it is a normal foot, a neuropathic foot, or ischemic foot, or a combination of neuropathy and ischemia, or you should be able to find out where any bony anomaly like hallux valgus or a plateau or any of these bony anomalies you should be, because they form the pressure points and high risk for ulceration there. So if after basic examination, if you're satisfied none of these complications are there, they're likely to develop in coming 10 years one of those complications. So they should be looking after for the following, for those signs, like every day they should be examining their foot both on the dorsum and plantar area, and they should be using moisturizers for dry skin. If there is ill-fitting shoe, they appropriate insoles and the bony anomalies, they should be using a custom-made special shoes. So no matter what, see all the basic, at some stage, all these diabetic foot should undergo basic vascular and neurological examinations. So ABI is what we have already discussed. So anything that is below 4 is a critical ischemia. 4 to 9 is borderline, and above 1 is a normal foot. One excellent tool is the duplex scan. Duplex scan is the Doppler scan that combines the normal ultrasound with the blood velocity across the vessels. So the advantage of this is that you can put the probe anywhere along the arterial system and know the morphology of the vessel and the blood flow across that. So the normal healthy Doppler is a triphasic wave. There are 3 phases in that wave, which shows an healthy, and it progresses to biphasic, and in ischemic or very compromised things, they become almost monophasic. Academically, there are sophisticated tests which can predict whether they're going to have any vascular compromise or any future compromise. You can use plethysmography is pressure changes. The pressure, they measure the pressure changes across the limb by applying differential levels of cuffs and volume changes. These are for more predictive and sensitive values. And there is a measurement of oxygenation across the limb also. We have a tool for that also. And the latest, if there is a vascular involvement, if you want to do any vascular procedure, or if you want to predict any necessity for future vascular procedures and beneficial value, we need a CT angio. CT angio is like a roadmap. With contrast, you do a CT angio, it gives a roadmap like a picture of the whole limb. This is the Doppler wave we're talking about. The first one is the systolic wave, and then the 2 ones are the diastolic waves. If all 3 waves are present, that means the normal good circulation. If one of the vessels, the phases are gone, that means the compromise are. This is how they do the monofilament test. You hold the monofilament in another instrument and ask the patient to close his eyes and then touch it in a normal area so that he knows how to feel it, and then test it across the foot in 2-3 points. These are the minimum points we should test. If out of 3 times, if he misses 2 times, if he can't perceive that, that means there's neuropathy. So this is a very classical this is a very classical slide which shows how people develop diabetic ulcers, non-traumatic ulcers. So if you see the middle one, so what happens is there is a silent, once there is a peripheral neuropathy, the blood vessels get crushed between the bony prominences and skin because of the abnormal moving patterns and shearing forces. Initially, it will start as a small subcutaneous hematoma, and then it expands and ruptures the skin. So for everything, you need a sort of scoring, so to know the severity and for comparative studies. So you can always say stage 0 is normal and stage 5 is the maximum. So one of the commonly used clinical classifications is the Wagner's classification, where a normal foot is score 0, and then a superficial ulcer is grade 1, a deep one is grade 2, with the pre-gangrenous and gangrenous changes in the forefeet at grade 4, and frankly gangrenous foot at grade 5. So these are the examples of how these grades look like. Grade 1 is just like a very superficial involvement of the skin, and they almost heal like any non-diabetic ulcers. Same principles of management. So grade 2 ulcers need a little bit of specialty care, debridement and continuous dressings, monitoring and all that. Infection treatment and infection prevention. And from grade 3 onwards, they need a proper surgical debridement and further treatment and reconstruction, or allowing them time to heal, and multiple procedures they may require. Grade 4 is like in borderline. They may heal or they may need a amputation at that level. So this is also a grade 4 where these sort of procedures are done more to save a life rather than limb. Because the moment you incise, let the pus off, you buy time to plan further procedures. These sort of grade 5 lesions, they go for frank amputation. So though the distal part looks normal, if you see the major part of if you see through that opening, you see the major foot of this is gone, and that is the area where the foot arteries are there. So they non-salvageable. This is a more academic classification where they use a combination of location of the ulcer, depth of ulcer, and infection and neuropathy combination. So all these diabetic foods, they need antibiotics. And whether it is vascular or whether it is neuropathic, they are usually infected. So we put them in a course of antibiotic. The moment you see, you start a course of antibiotic. So there's a mild, moderate, and severe varieties. For the mild ones, we usually prefer something like augmentin. Moderate infections, you go for combination antibiotics and cephalexins, and very bad infections, you treat them with imipenem, meropenem, and tocoplan and all that. So now we have an ulcer with either a ischemic ulcer or a neuropathic ulcer. For the ischemic ulcers, there are various vascular interventions like angioplasty, stenting, and all that. To start with, they need to be put on silastazole, aspirin, clopidogrel, Clexane. For acute cases, Clexane, heparin, and other things. I'll skip through the slides because I think we're running short of time. So,
Sorry to interrupt, Dr. Rama Rao. Can we have a summary? We are just running short of time
yeah,
here.
that's what I'm saying. So for frank ulcer management, so even before you operate, we have to have a plan how we are going to treat that ulcer, close that ulcer. So all your incisions or debridements, taking of bone, everything should be planned before you start incising. So skin flaps and all that we design so that they will close over the underlying ulcer later on. So what are the principles? The principles are sharp debridement. They are all high risk for anesthesia. So they would have already had a cardiac disease and other complications. So they badly tolerate a general anesthetic. So ankle block is block we use for all these foot lesions. So principles are debride all dead tissue, let off all collections, and then I'm not going to discuss, ma'am. So basically, all these dressings are more fancy rather than more fancier stuff that we're not using anymore. See, what finally helps is the classical gauze dressings, gauze pads. So these are some of the cases that we have recently handled. You see an elderly man with a burn to midfoot, debridement followed by constant dressings, and at the end we used epidermal growth factor ointments, which are when there is no infection, when everything is fine, there's a clean bed, they work very well in sealing of the incision, ulcers. Classical neuropathic ulcer, they improve with debridement and offloading and dressings. So this is very elderly man. He came with an exposed metatarsal. We expose. You can see the bone in the first slide, first part. So we excise the bone. We put a VAC therapy for some time, and the granulation is there. Then that's the time we start treatment. Instruct the patient how to take care of his foot, and finally heals. The second one is the healed one. There are a lot of fancy stuff. Stem cells, Some people use mesotherapy for that is platelet-rich plasma for a clean ulcer. We use vac therapy extensively. Vacuum-assisted closure is a constant suction. The device helps in granulation and taking of the infection and helps in rapid healing. This is how a vac looks like. I think we are running short of time, so we just... Yeah, summary is do a good physical exam, start antibiotics as soon as possible, refer for surgical evaluation, do frank euglycemic range, and screen other systems. At the end, you should teach the patient to take care of that ulcer and also give him enough knowledge to prevent future ulcers from coming up. And we should offer them continued support. Thank you.